Dr. Hilda Boy. Dr. Hilda Boy, please, are you here? Okay. So whilst we get Dr. Boy, we are going to call on the president of the Patients' Rights Watch Ghana. That is Lawyer Isaac Giabo. Please forgive me if I don't pronounce your name right. Lawyer Isaac Giabo. He's the president of the Patients' Rights Ghana, to give us a welcome address.
Okay, thank
Lawyer
you.
Giabo, please, are you here? Thank you very much.
I can hear you loud and clear. Thank you, Dr. Nelly. Hi, everyone. I'm so blessed and happy to join this important webinar marking such an important day. Can we envisage a world in which no one is harmed in healthcare and every patient receives safe and respectful care every time and everywhere? That is exactly the goal of the World Health Organization's Global Patient Safety Action Plan 2021 to 2030, which seeks to reduce to the barest minimum harm suffered by patients at the point of care. The World Patient Safety Day is therefore a crucial cog on the wheel of WHO's Global Action Plan towards safety in terms of raising public awareness, fostering collaboration between stakeholders, and empowering patients. This year, the theme for the World Patient Safety Day, for which we are gathered here tonight, is Safe Care for Every Newborn and Every Child, with the slogan, Patient Safety from the Start, which seeks to recognize the vulnerability of newborns and children to risk and harm caused by unsafe care. We all admit that children are vulnerable compared to adults. Indeed, a single incident in the life of a child can have lifelong consequences for a child's health and development. Unfortunately, children have no voice of their own, and they rely on adults, which is you and I, to speak up and make decisions for them. That is why tonight's webinar is so important. And just so that we all know, tonight's webinar is a gathering of legal minds and medical experts to think through and discuss issues bordering on the safety of our newborns and children. Before I end my welcome speech, let me take this opportunity to remind all of us of the global objectives of the World Patients Day. This objective runs globally, including what we are gathered here to achieve tonight. The first is to raise global awareness of the safety risk in pediatric and newborn care in all healthcare settings, emphasizing the specific needs of children, families, and caregivers. Number two, to mobilize government, healthcare organizations, professional bodies, and civil society to implement sustainable strategies for safer care of newborns and children as part of broader patient safety and quality initiatives. Number three, to empower parents, caregivers, and children in patient safety by promoting education, awareness, and active participation in care. Lastly, but not the least, to advocate for strengthening research on patient safety in pediatric and newborn care. On behalf of the board and management of the Patient Rights Watch, I would like to extend my sincere gratitude to our esteemed resource persons who have made time tonight to share with us their knowledge, the leadership and members of the Pediatric Society of Ghana, our collaborating institution, sponsors, and of course you online for making time to join us tonight and to join all this important conversation. Thank you for coming, and I hope you enjoy ourselves tonight. Back to you, Madam Moderator.
Thank you so much, Lawyer Giabo. This is very insightful. I mean, one of the key things I picked from what he said is to advocate for patient safety in pediatric and newborn care. You know, sometimes as a pediatrician, when you are pricking a baby and you're looking for a line and the parents are giving you the side bombastic eye, you just feel like, what are you doing? You are trying to get a vein for them, and sometimes it looks like the parents don't appreciate, in quotes, what you are doing. Is it wrong when you are trying to get a vein? Are you harming the baby? what if your faith does not permit your child to receive blood transfusion or a certain form of treatment? Today, we are going to address all of these topics right here. And we are going to start with our very first speaker, her profile. I will try and keep it very brief. So she's a proud alumni of the Wesley Girls High School in Cape Coast. And then she headed to the Kwame Nkrumah University of Science and Technology, where she obtained her bachelor's degree in science in medicine and surgery. She's a member of the West Africa College of Physicians, a fellow of the Ghana College of Physicians and Surgeons. She has a Bachelor of Law degree and a qualifying certificate of law. She's a senior lecturer with the Department of Child Health, SMS, in Kumasi, and an honorary consultant pediatrician with the Konfanoche Teaching Hospital. Today, she will be presenting on preventing harm in neonatal and infant care in Ghana. Please help me welcome Dr. Jikwa Plandru. Thank you very much.
Hello, good afternoon, everyone, and thank you very much for your kind introduction. I have just started sharing my slides. Can we see them?
Yes, please, we can.
I'm trying to put it into slide. Good, great. Okay, yeah, so good afternoon again, or good evening, and thank you very much to the organizers for giving me the privilege of sharing this very important topic. So in 25 minutes, I'm going to try and, just quickly whiz through the spectrum of, share a few thoughts on the issue of harm. I think that one of the biggest challenges that we face is there's just so much to talk about. And I realize that I may not be able to cover everything, but I know that there are lots of pediatricians online who will fill in any gaps that are there. So let's just quickly go into the topic. So just so that we're on the same page, just a few definitions. So WHO defines harm. Harm is any physical or psychological injury, suffering, disability, or death that results from healthcare or treatment rather than from the underlying disease or injury. Now, I'm sure that any of the pediatricians online will agree with me that this is a very, very difficult determination to make. The second definition I would like to introduce is one of patient safety. So patient safety is the absence of preventable harm to a patient and reduction of the risk of unnecessary harm associated with healthcare to an acceptable minimum. Now, so based on this definition, I think I just want to point out that there is some necessary harm and there is some unpreventable harm. I've heard a lot of discussions about if you have to set an IV line, you've got to prick that patient. You do it as skillfully as possible, as painlessly as possible, but it is harm. You're breaking the skin and causing some pain. So depending on the degree of inherent or pre-existing vulnerability, the way one infant will handle necessary harm, my slides are, the way one infant will handle necessary harm may differ from case to case. So setting an IV line on a tiny little 600-gram preterm may be quite different from setting that same line on a full-term or an older infant. Quickly, so just to make the comment, harm as defined above exists clearly on a spectrum. And it's almost, it says harm that is caused by the treatment rather than the disease. However, in practice, it's almost never 100% due to disease or 100% due to the treatment. So just two quick illustrations. You have a 23-week preterm, 500, preterm baby weighing 500 grams. You cannot treat that child in most of our hospitals. So the family is counseled, the baby is kept warm and safe and as comfortable as possible. And after 2 hours, that baby, unfortunately, has passed away. That is, I think that most people would agree that that's 100% disease. The other extreme would, just as a quick illustration, would be a healthy child about to be discharged, is wrongfully given a dose of a medication because the medicine was incorrectly labeled. So the nurse who was given it thought it was an antibiotic. It turned out it was quinine. The child gets this injection and dies. That clearly is 100% due to the treatment. In reality, most cases are way, way, way more complex and fall, in between on this spectrum. So quickly, 3 other definitions. A newborn, for the sake of those who may not be familiar with the terminology, a newborn is a baby up to the 28th day of life, newborn or neonate. Some people reserve, newborn for less than 1 week, but for this presentation, I'm using them interchangeably. A preterm baby is a baby born before the 37th completed week of pregnancy. So pregnancy typically will go up to 40 weeks. So if the baby is born before 37 completed weeks, the baby is considered preterm. And an infant is a child below the age of 1. Now, I quickly want to make a few comments about some of the things that happen before the health facility, before the children get to the health facility. And I'm sure that these are things that all our pediatricians will be very familiar with. So before children get to the hospital in Ghana, some of the factors that can contribute, to bad outcomes. We have some social and cultural influences that can play a role in negative outcomes. I'm sure I use a lot of pictures, so I hope nobody will be, but these are some of the things. This is a child who came with an infection because before the child came to the hospital, the child had been taken to a traditional healer, and all these cuts were made in the child's abdomen and various herbal things instilled. And so by the time this child came, this child was very, very septic. Some children tend to present late in the course of their illnesses, and that also always makes the outcome worse. Some children have undergone harmful herbal treatment, which not only delays medical presentation, but can also cause direct harm. We had a case a while back of a child who had a cold, and I think the grandmother dropped shea butter into the baby's nose, and the baby aspirated it and died. So these are, and then of course there are cases of unrecognized child abuse, which can also be contributing factors. On the way to the hospital, we are often faced, some of the things that can increase the risk of harm is that we often do not have enough ambulances. The ambulances are not always well equipped with child-friendly equipment, and they're not always free. So there have been cases where, charges have led to a delay in the child coming. And then children are sometimes brought to hospital in all kinds of vehicles, and some of them are very unsafe. This is a picture of a baby who was 3 days old. The mother was bringing the child to the hospital for postnatal care, and they sat in an aboboya, and the baby was thrown out. And of course, I've hidden the face, but this is a child at 1 year. When you see the posture and the way the hands are, immediately you will know that this is a child who has severe brain damage, because this child had a very bad injury. I know we are going to talk about, there'll be a separate presentation on obstetrics, so I won't dwell on this slide, just to say that some factors can be related to delivery, and this is a child with a bad fracture. But as I said, there'll be another presentation, so I'll skip this. So we've talked about some of the things that contribute to harm before the children get to the facility. And as I said, I may have left some out. So what happens in the health facility? Well, so the first thing I'd like to, maybe throw a little bit of light on is the question of why are infants and children particularly vulnerable to harm? And I'm sure some of these will be pretty obvious. If you've never seen a tiny little premature baby, this picture is probably about 20 years old. So obviously they are a highly vulnerable and fragile population. They are difficult to diagnose. Obviously, they cannot tell you what is wrong with them, and therefore, pediatricians need to exercise a lot of skill to work out exactly why this particular baby is ill. They are very immature, and they're also rapidly changing. So they are interpreting their lab results, a figure that would be abnormal on the first day of life might be normal on the second day of life. So they are rapidly changing, and we need to be very careful when we are interpreting their labs and things like that. They have very little immunity to infection, and the biggest protection from infection, which is breast milk, is often not given to them for various reasons. They have limited reserves of everything: heat, energy, blood sugar, and so these are all some of the things that will contribute. Other reasons might be that sometimes they are injured by traumatic deliveries. They can have undiagnosed and unsuspected birth defects. So this child in the picture is a child who was born with a skin condition. Every time you touch the child's skin, it peels off. Now, clearly that baby, right from the word go, is susceptible to infection. And then these are tiny little premature babies with very little immunity. So they can be born prematurely, that is too early or too small or too late or too big. So these are some of the things that, these are some of the reasons, a few of the reasons why infants and children are at risk of harm, why they sometimes do not handle treatment very well. So we quickly want to look at a few issues. One of the challenges with these tiny little ones is just issues to do with medication. The dosages of their drugs are often really, really tiny. And they are given according to weight. So you need to calculate the weight of the baby and the dose, and whereas with an adult, so if you're given an adult paracetamol, you would just say, take 2 tablets of paracetamol of it. But if your baby weighs 1 kilogram, then you need to work out, 15 milligram per kilo, do the math. It can be quite tricky, and we need people who are experienced, because even a tiny mistake can hurt the baby. So sometimes the challenges with medication are due to equipment. So this shows, you're going to give a tiny little preterm baby just this little amount of drug in the syringe, and you're supposed to give it over 15 minutes for the safety of the baby. This is an infusion pump, which is a piece of equipment which we use when we have these tiny little babies. Unfortunately, many facilities do not have them or do not have enough of these. And so you're forced to give these tiny little babies, fluid straight from the syringe. And that can be very, very challenging. So when you're given medication, we always, when you're dealing with these tiny little babies, we always need to bear in mind the 5 rights of medication administration. Make sure it is the right patient you are giving the drug to. And of course, for these tiny little newborns who, if the baby is just, a few hours old, you need to be absolutely careful and clear that you are dealing with the right patient, because it is, if you're not careful, you could easily mix 2 babies up. Make sure you're giving the right drug, the right dosage, the right rate. If it's supposed to be over 15 minutes, you must do it over 15 minutes. Make sure it's the right method of delivery. Most of us are using electronic medical records. We need to be careful that we document our drugs correctly. And whatever the system, when we had paper, people would sometimes cancel and make it, you're not supposed to do that. So whatever your system permits, make sure you stick to it. So we've talked about some of the issues that can occur, why newborn medications can be very, very tricky, and we need to be extremely careful. Another source of harm which can occur to infants and children, of course, I started by saying that one of their challenges is that they tend not to have very efficient immune systems, and therefore they tend to be at risk of infection. Hospitals are inherently high-risk places for infection, and we need to have strict infection prevention protocols which need to be observed. We need to make sure that these children get their breast milk if they possibly can, because breast milk really protects children from, especially newborns, from infection. Hand hygiene is critical. One of the challenges you somehow face sometimes, well, this picture on the right obviously is very dramatic, but long sleeves, painted nails, lots of jewelry on the hands are extremely dangerous because they can harbor all sorts of bacteria. And if you're wearing sleeves like this, you can't wash your hands. So it's very critical. But unfortunately, many facilities have issues of inadequate supply of hand sanitizer. Even water is sometimes a challenge. Poor attitudes of, staff. Sometimes, the staff, we ourselves do not take as good care of our hands as we should. You should wash your hands, before you touch a baby. Before you touch any baby, wash or sanitize your hands. Mothers are sometimes not allowed access to their babies. Often the mothers are the safest people to handle the baby, because even if the mother has an infection, she will provide some protection against the infection in her breast milk. But sometimes in some facilities, mothers are not allowed to have as much access to their children as they should. And we sometimes feel, oh, the mothers are not clean, but actually they are often the safest people. Still on infections, many of our facilities suffer from just too many babies. This picture was taken from where I used to work. This is a long time ago, Confanochi Hospital, probably a very, very long time ago, before we got our new facility. But clearly, with all these babies, lying side by side, so close together, the ward is just full. Infections are going to be transmitted. So it's important that we manage overcrowding. Procedures are not always, we need to do procedures in a way that reduces the risk of infection, and access to where newborns are on admission should be limited. Sometimes, you see children, older children with colds being allowed to come into the newborn ward, and that's very dangerous for some of your small babies. So infection prevention is extremely important. As I said, hand hygiene, hand hygiene, hand hygiene. It's way, way, way more important than changing shoes. Many facilities are very fixed on changing shoes. So you see people, everybody comes in, changes their shoes, and then, many people do not wash their hands and begin to touch babies. We need to be very careful about things like where if you set a drip. So if you look at this picture, it shows a drip which has been set. I don't know whether you can just see the drip peeking out here, but the whole hand of the baby is bandaged. And the reason why we do that is because often the quality of plaster is quite poor. And so you need to put, an extra layer of gauze to cover the hand up to make sure your drip doesn't come out. But the danger of that is that you can end up with an infection, and this infection in a young child can become serious. So it's important that we have aseptic management of our lines, proper equipment and surface cleaning. We need to support breastfeeding, and we should encourage mothers to handle babies more than health workers. I visited a facility in South Africa, and mothers do everything. The staff hardly touch the baby. The mothers they will hold the thermometer and then show it to the nurse to read, but there's minimum handling of the babies so we're still talking about sources of harm to infants. And as I said, there are many. We want to quickly look at some of the issues to do with equipment. So many facilities have equipment that is outdated, malfunctioning, or unsuitable for use with infants. When you do get equipment, often maintenance is a challenge. And some of these things, we're looking at sources of harm to children. Some of these things, can cause big problems. We have poor maintenance culture. We have power fluctuations. You get a brand new incubator, and within a couple of months, it just doesn't work anymore because of challenges of replacing parts, power fluctuations. So in this picture, many people will be familiar with pulse oximeters, especially from the COVID time. Now, this is a pulse oximeter which measures the amount of oxygen in a baby's blood. The picture on your right is my finger in this probe. This probe is designed for an adult finger. And yet very often, even on the newborn ward, we still, the probes we have are not probes for babies. So you see that in this picture, the baby's foot has been stuck into the probe. And when you do that, you're not going to get an accurate oxygen saturation, which is an important tool for your managing the child. It will determine whether you need to give oxygen, whether you need to reduce the oxygen, and so often, there are challenges with consumables like syringes, cannulae, nasal tubes for all sorts of things. Very often hospitals tend to focus on adults, and we don't always have enough of things, the syringes that we need for the tiny babies, the tubes for feeding. Sometimes you have a baby who has a bladder that you need to empty, but you don't have a proper catheter. I don't know whether there's any pediatrician online who has never had to improvise, by using a feeding tube to enter the bladder of the child, and that can be a source of harm to the child. So just talking about equipment. Fortunately, I think all the pediatricians online, I doubt any of you would ever have seen this before, but this is a baby. The baby on the left is not breathing properly, and the health worker is using this piece of equipment called an ambu bag to sort of get the baby to breathe. This health worker on the right, and this, as I said, it's a very old picture. You won't see it very much anymore, but this is a health worker who has a baby who cannot breathe, does not have this bag, and is using an insu bottle to blow into the baby's mouth. Now, it will get the baby breathing, but it means that if this health worker has an infection, it can be transmitted to the baby. But as I said, this is probably, very rare in the system, but it used to be quite common. And the reason why I put it in is because every now and then you still see health workers having to put their mouths directly on a baby's face and blow into the baby's mouth to get the baby breathing, because they don't have this. And obviously that's a risk to both the health worker, because if the baby has an infection, the health worker can pick it. If the health worker has an infection, the baby can pick it. So equipment can be a big challenge. What do we do? Facilities must have rational equipment policies tailored to the kinds of patients seen there. And with end user, it's very important to involve end users. You know, when things are being bought, when consumables are being bought, is this the right size catheter? Is this the right size syringe? You know, and involve the end users. There should be planned maintenance of all equipment. You know, we need to be careful when we are buying equipment. It's very nice to, you know, you get some funding and you get a really, really fancy incubator, but you don't have what it takes to maintain it. Don't accept it or don't procure it. Be careful about gifts. Very often, newborn units get large, you know, donations of gifts from all over the world, and you open them and there's very little you can use. So you need to be extremely careful that we don't clutter up our system with gifts which are not functioning. Quickly to move to the environment and a few other issues. What are some of the issues in the environment? There are many. I think that we always need to walk in our facilities and look around for places that can be dangerous to children. So again, this is an old picture from Komfo-Anokye. And if you look, these bars are supposed to protect the children, but you can see the children, this little girl is swinging through the bars, which means she can easily walk through it. And when she walks through onto this surface, that she'll fall over to the place where ambulances come running. So clearly that was a hazard. And we quickly pointed it out. When we saw this, we pointed it out to the hospital, and very quickly they put metal bars in between to protect the children. Sometimes we don't have adequate spaces for our children. And again, this is a picture from my own hospital before we got our new facility. So many babies come in and there's nowhere to put them. So you have to put them on a table. Of course, there's a risk of, you know, a baby falling off. Sometimes you go to facilities where there are babies, but the beds don't have functioning side rails, and the children, it's possible that a child can, you know, sometimes you have, I'm sure every one of us has worked in a place where the incubator doors are taped with plaster to, you know, to stop them from opening. And all of these are environmental hazards that we need to look through our facilities, and, you know, and make sure that our babies are absolutely safe from falls. This is another picture still on the environment. This for me is the picture that made us, you know, absolutely determined that we needed a new newborn facility. I was at home. I was at home one dawn when one of our doctors sent this picture and said, you know, Dr. Plandrew, we cannot go on this way. They were just bringing babies and bringing them. And, you know, many times you would say, it's enough, we are full, we are not going to admit anymore. And then they'll bring this very sick child who needs oxygen. And so you can see 8 babies packed together in a cot. Not only are they sharing infections, they're sharing oxygen ports, the tubes are crossing all over the place. These are very dangerous things. I'm very happy to say that, this picture has been shared quite a bit, you know, but I'm very happy to say that that is not the case in Komfo-Anokye anymore. Fortunately for, grateful to a former First Lady for assisting in the conduction of a new mother-baby unit. But I'm sure that there are still facilities that face this kind of problem. So environment, equipment. So we are running down, we'll be rounding out soon. So it's important, you know, another hazard, you know, which it's probably does happen occasionally. It's important to prevent mix-ups in babies. When a baby is born, you must have a system of making sure that the baby is properly identified. So many hospitals just use this wristband. So when the mother is in labor, before the baby comes out, the wristband is labeled with the baby's name, the sex, the weight, and all that. And so that as soon as the baby comes out, the baby is quickly labeled. The challenge sometimes is that the labels may be too big. And so you can see these tiny little preterm twins, they have the labels on their arm, but they're at risk of slipping off. And so every hospital must have a system for identifying babies. We know that there are much more advanced tracking technologies. Some facilities use CCTV cameras, you can have scannable barcodes, you can use biometric identifiers, but all of these solutions come with significant costs. And so I think many facilities in Ghana just use a wristband to label the baby. It's important, therefore, to have consistent procedures along the line. When the baby is born, we label. We must, other things that will help in making sure that babies are not mixed up is that we must minimize separation between mother and baby. Ideally, there should be no separation, but we know that sometimes it's unavoidable. The baby may be ill, may need to be whisked off to the intensive care unit for treatment. The mother may be ill, but as much as possible, let's try and keep mothers and babies together. Another practice, I don't know whether this still happens anymore, but I remember when I was, when I was training, it used to be the practice that when the baby was born, we would show the genitalia to the mother and ask the mother, what did you have, a boy or a girl? And then the mother would say boy. But I don't know why we don't just show the whole baby. Yes, show the genitalia, but definitely show the mother the face of the baby. Let her look at the baby so that in case there's any, problems afterwards. Okay, so I'd like to end this with just to share a few general thoughts on the issue of preventing and reducing harm in infants and newborns, which cuts across the issues of equipment, drugs, and everything. We need to focus on training, but very importantly, we need to focus on retaining a greater number of specialist nurses and doctors. There was a slide that I wanted to show, but I wasn't able to get hold of it. But this was Prof. Alexander Menu's work, where he was just looking at newborn care in different facilities. And one of the most scary slides that he showed us, he was showing us year to year, the number of specialist nurses, pediatric nurses, newborn care nurses who are just leaving. Now, if you have a newborn trained nurse who can feed a 26-weeker without choking the baby, that's a skill that is worth retaining. And unfortunately, so we need to focus on training and retaining. We should have comprehensive national protocols. We have protocols for many things, but we don't have protocols for everything, so that everybody knows if I receive a baby with jaundice, I do 1, 2, 3, 4. Whether I'm in Komfanochi Teaching Hospital or I'm in a district hospital, we have protocols so that everyone knows what to do. And these protocols need to be clearly displayed. They should be accessible, and people should be trained in them. We need to conduct regular, non-punitive performance audits at the facility level to allow real-time discussion of adverse outcomes. Sometimes what happens is that there's performance review, in the region. And so we need to quickly rush and, decide which baby are we presenting. But by the time you are presenting, a lot of the things would have been forgotten. So it's important that we perform audits of when you have especially when you have a bad outcome, a death or an injury or something like that, we should be able to quickly audit. We should prioritize immediate documentation of incidents as they occur so that swift action can be taken to address identified issues. There used to be these incident books. I'm not sure how the LIMS deals with this. Some facilities still have incident books, and it's important to document these things so that we can discuss it dispassionately. We need to continuously observe these children when they are under our care and keep a close watch. This is a picture from one of our facilities where, very sadly, you see mothers on the floor with their babies because the ward is just full and there's nowhere for them to sleep. And this is obviously terrible, and I don't think any facility would like this to happen. But the one good thing is that the babies are with their mothers. This picture is, it's a sad picture of a baby who was injured on the ward in another facility many, many years ago because somebody was setting a drip and accidentally the tourniquet that was being used, that's you tie something, the veins stand out, and it was left. And unfortunately, the baby's hand became badly damaged and the baby ended up losing the hand. But I'm putting this picture in because very sadly, the baby's grandmother, saw the tie. But she said, I saw it, but I thought it was part of your treatment. So I didn't want to say anything. It's very important that we encourage mothers and carers to report any concerns they notice. We should view them as partners, because they, if we encourage them and, we are respectful to them, we encourage them to speak up when they see things that are wrong, we will be able to prevent some of them. I'm sure that if the grandmother had had the courage on the first day to say, I think you've left something on my baby's hand, the baby wouldn't have ended up like this. So these things are happening. Advocacy is very, very important. It's essential to advocate for infants and newborns, because policymakers do not always recognize the value of allocating funds to them. If you have a space and you have to choose between using it for a VIP ward for the big people to come on admission, or use it for a ward for feeding malnourished children, if you don't have a child, an advocate, and on that note, I cannot talk about advocacy without giving a big shout out to our Pediatric Society. I mean, you have been fantastic advocates in everything from jaundice to breastfeeding to child safety, cervical cancer, everything. So you're really an amazing team. So thank you so much. And this, I think, is my last slide. And the last point I want to make is a litigious environment helpful? There have been many lawsuits related to medical negligence. They're becoming increasingly common. Courts are awarding significant compensation to parents, to families. Now, I think it is absolutely, don't get me wrong, it is absolutely important that when there are legitimate cases of negligence, we must deal with them and, but I think we also need to recognize that we're in a very fragile system. If you've been in Accra, there are many very nice, well-equipped facilities, but the further you go outside the capitals, the facilities are often very, very challenged. And the more we, the challenge, if you know what happened in the United States, that as the litigation increased, medical care became more and more expensive because people became very defensive. So if I have a child who has meningitis, instead of just doing a lumbar puncture, confirming my meningitis and treating, I will go and do an MRI because I don't want trouble. And it makes medical care. So I think that as we think about these things, we need to consider the environment. When the environment is very sort of hostile, it discourages open conversations about errors for fear of legal consequences. So I'm definitely not saying that we should not be held accountable, but I think that we need to bear in mind that a lot of these cases are very controversial. Some of the harm falls in here and needs to be looked at. This is the minister says that we're paying approximately 10 million on medical negligence. So in conclusion, I would just want to say that it's impossible to completely avoid harm in the medical care of infants, but it's possible to minimize it with meticulous and thoughtful medical care. Parents and families are an important asset when it comes to minimizing harm, and we must see them as such by providing respectful care and allowing them as much access to their children as possible. The system is fragile, and everyone has a role to play to make it safer and to reduce harm. The society as a whole, policy makers, definitely health professionals, the courts, everyone. We all have a role to play in making our facilities safer and better for our children. So thank you very much. That's my last slide. Thank you. Thank you for inviting.
Thank you very much, Dr. Plandrew. I really enjoyed listening to you. Thank you so much. Everyone indeed has a role to play. And one of the important cues I took from Dr. Plandrew's presentation, the five rights of medication administration. It says the right patient, the right medication, the timing and rate, the dosage, the method of delivery, the documentation, and then we should learn to round up doses. Very, very important. Thank you so much. And that we should also view the caregivers as partners and not as inconvenience. Thank you so much. On that note, we'll move to the second presentation for tonight, and a quick profile on our second presenter. He's an alumni of the Pope John Secondary School in the Eastern Region, Pope John Secondary and Minor Seminary. He obtained his MBCHB from the University of Ghana Medical School. He's also a member of the Ghana College of Physicians and a fellow of the West African College of Surgeons. He has a PhD, that is Doctor of Philosophy, from the University of Please forgive me if I can't pronounce this well. Utrecht in the Netherlands. And he's currently the MP for Lambusi. So please, ladies and gentlemen, our second presenter will be talking on the link between obstetric care, neonatal, and child safety in Ghana. Honorable Prof. Titus Bayu, the floor is yours. Thank you.
Dr. Nelly, I understand Prof. Titus will want to take the last slot because he is currently engaged. So if her Honor, Mrs. Gloria Mensah can take her.
Okay, thank you very much. So then we'll move to our third speaker. Our third speaker, so I'm going to give a quick profile about her. She's also an alumni of the Ghana Secondary School in Koforidua. She holds a Bachelor of Law degree and then a qualifying certificate of law from the Ghana School of Law. She also served as a district magistrate from 2016 to 2020, and currently she's a circuit court judge, a position she's held from August 2020 till date. She works in a specialized child-friendly gender court where she deals with marital issues, defilement, and other sexual offenses, amongst others. Today, she'll be presenting on the rights of child patients, upholding the welfare principle in healthcare delivery in Ghana. And that will be done by Her Honor Gloria Mensah Bonsu. Madam, please, the floor is all yours. Thank you.
Good evening, everyone.
Hi, good evening.
Good
Yes,
evening.
I'm grateful to you for having me on this program and giving me this opportunity to discuss this topic with all of you.
Good evening, madam.
Please, can you see my presentation?
Yes, please, we can.
Yes, I'm having a
madam.
challenge. Also, you have to be taken on. Take this one. All right. All right. Thank you very much. So tonight, my topic for discussion is the rights of the child patient, upholding the welfare principle in healthcare delivery in Ghana. So the first thing for us to ponder about is who is a child? And we are saying that a child is a person below the age of 18 years. And then we ask ourselves why this talk matters. This talk matters because children are among the most vulnerable patients in healthcare. Every day in Ghana, a mother carries a feverish child to the chief's compound or hospital. And in that moment, the child is more than a case. She is a person with rights. And when we honor those rights, care is safer, faster, and kinder, and lives are saved. From this, we could see that every child has a right. What we are saying is that the child's right is rooted in what we call the welfare principle. What is the meaning of welfare principle? welfare principle is that the child's best interest comes first in every decision. It is the golden thread running through all matters relating to children. Not what is easiest for the system, but what keeps the child safe and well. So anytime you are confronted with any issue with the child as a healthcare provider, you ask yourself, if this were my child, what would good care look like? This means you have a duty of care, which is also a legal duty. The Constitution of Ghana and the Children's Act makes it a legal duty that the child's welfare should be a primary consideration in any decision making. Hospitals and CHIPS facilities also share this legal duty through their policies and SOBs. So under the welfare principle, it is mandatory that in emergencies, you treat the child first, paperwork later. What is the basis for the welfare principle in Ghana? We have the constitutional, statutory, and international laws as our basis. Let's look at the constitutional provisions. Article 28(4). 28(4) of the 1992 Constitution provides that no child shall be deprived by any other person of medical treatment by reason only of religious or other beliefs. Article 13 further secures the child's rights to life. And Article 34(2) requires the state to make direct policy towards adequate medical and health facilities for children. Let's look at the statutory provisions. The Children's Act 1998, Act 560, remains the principal legislation in Ghana governing child rights. Section 2 declares that the welfare of the child shall be paramount in all matters concerning the child. And Section 2.2 also provides that the best interest of the child shall be the primary consideration by any court, person, institution, or other body in any matter concerning a child. Section 8 also provides that no person shall deprive a child of access to immunization or adequate diet, medical attention, or any other thing required for his development. And then Section 11, it says that no person shall deprive a child capable of forming views the right to express an opinion, to be listened to, and to participate in decisions which affect his well-being. The opinion of the child being given due weight in accordance with the age and maturity of the child. International laws. Ghana ratified the United Nations Convention on the Rights of the Child, UNCRC, in 1990. African Charter on the Rights and Welfare of the Child, ACRWC, in 2005. Both instruments stress the welfare principle of the child. Now we want to look at the core rights of the child patient, because the child patient has the right to health and medical care, right to life-saving and timely care, right to be listened to, right to protection from harm, right to privacy, confidentiality, and dignity. So when we talk about the child's right to health and medical care, we are talking about a duty which is imposed on the state to provide facilities and on parents to ensure the child enjoys preventive, curative, and rehabilitative health services. Their right to life-saving and timely care. It says that no child should be turned away in an emergency by a doctor or healthcare provider. Then right to be listened to. While parents or guardians usually provide consent, children capable of forming views are entitled to be heard. The right to protection from harm. This includes protection from medical negligence, harmful cultural practices, and unsafe medical experimentation. Then right to privacy, confidentiality, and dignity. Health professionals must balance parental involvement with respect for the child's dignity and privacy, especially in adolescence, so that in times of sensitive examinations, there will be a chaperone or curtains will be closed. At this point, I want us to look at the effect of the welfare principle as against the parental authority versus child's rights. That is what happens when a parent who is supposed to give consent refuses to do so. The Children's Act vests responsibility for a child's welfare in the parent or guardian. At all material time, parents make health care decisions for minors. However, parental authority is not absolute. There are exceptions when consent may not be required. So the first exception is where there is a need for emergency treatment, so that a parent's refusal of life-saving treatment for the child, or where there is no parent or guardian available in time, but there is a need to prevent serious harm. Such situations, the courts and healthcare, we can look at statutory exceptions. That is where, for example, Ghana Health Services guidelines allow adolescents to access certain services, example, family planning, STI treatment without parental consent. These provisions are grounded in public health and human rights obligations. So where we have mature minor doctrine like liberated children or emancipated minors below 18 years, like street children, kaya youth, and then they can have their own, give their own consent because they usually don't have any parents, yet they are less than 18 years of age. Then we have the judicial intervention. The high courts, circuit courts, and district courts have worship jurisdiction over children. So in emergencies, doctors, healthcare providers may act under the doctrine of necessity. And the court consistently prioritize child welfare over parental beliefs and consent withholding. I want us to look at everyday Ghana example and what as a health worker you can do. For example, in immunization day at a CHIP facility, parents has already given consent, yet because the child has rights, it is incumbent on the health worker to explain to the child what to expect. Let's say a 16-year-old with a private concern, he wants a STI treatment or family planning. It is incumbent on the health sector provider to give privacy and involve a trusted adult when it is safe. Let's look at this case scenario: refusal of blood transfusion. Child critically ill and requests urgent blood transfusion. Parents refuse on religious grounds. The courts uphold the welfare principle and says that the child's right to life overrides parental refusal. I want us also to avert our minds on respecting privacy and data protection. And I will refer you to Cybersecurity Act 2020 at 1038, section 62 to 63. It will tell you that you should not post a child patient's photo or folder on WhatsApp or social media because it has legal consequences. When you read it, you see. And because the child has privacy which should be respected, You have to keep voices low around bedside, close curtains for sensitive conversations. And you are not supposed to share information. You share information on the child on a need-to-know basis. And you must be able to store the records safely so that it does not get into the hands of the wrong people. I also want us to ponder on proper documentation that will protect the children and you from any legal suits. Whenever you are dealing with such cases, emergencies and all that, you have to write legibly what you saw, what you did, and why. And in emergency situations, you treat immediately, document, and inform the family promptly. Then when it comes to report incidents early at appropriate quarters. Then the documents, you must also show whom you inform and the plan you used in simple words. The health workers pledge, as I've been told, is that every child I meet today is my responsibility. And as a result of that, the child welfare guardian pledge for everyone should be, I will put the child's best interest first in every decision. I will speak up for safety, even when it is uncomfortable. I will explain, listen, and show kindness always. I will protect privacy and never share patient images or data unlawfully. I will learn from mistakes and help my team to do better tomorrow. Thank you very much.
Wow. Wow. Thank you so much. So many laws backing the rights of children in Ghana. So many laws. So many laws. I was just looking at them in awe. I was like, oh my goodness. Thank you so much, Anna. We are so grateful. So the core rights of the child patient, the child has the right to health and medical care, right to life-saving and timely care, right to be listened to, right to protection from harm, and then right to privacy, confidentiality, and dignity, and so many statutory provisions. Thank you so much. And as you were giving the presentation, I realized you were also answering some of the questions that came up on the Google form. A question about transfusion, a parent not accepting transfusion. So I was glad you touched on that as well. Thank you so much. We are grateful. Please, Prof. Titus Bay, you on the call? Prof, please, are you on the call? Prof, please, are you on the call to give us the last presentation for the evening? Okay, so I doubt Prof. Bayo is on the call yet. And so we'll move on to answer a few questions that we have. Please, you can put your questions in the comment section below. We'll try and address them. We'll try and address as many as we can. We had a few questions on the Google form that we circulated around. And then kindly note that the CPD form is in the comment section. So please do well to fill the form to get your CPD points. The administrator has put the link in the comment section. So please do well to fill the form to get your CPD points. Because I got a number of questions from people asking how their points will be obtained. So one of the questions I got, so Dr. Plandru, please, this will go to you. Can I request for my child's hair not to be shaved for an IV line? Can I request for my child's hair not to be shaved for an IV line? Thank you. Please, if you can help us address this question.
I mean, certainly you can request and you can state, that you would want it not to happen. But again, I think that we usually will not go to that unless there are no other available lines. So it's always about weighing the sort of risk versus benefit. If you have a child who is deeply in shock, and the only line that you can get, and I'm sure that pediatricians online, anyone who has worked with newborns or young children, has found themselves in this situation where the limbs are so cold, maybe the child has bled. I don't think that if you explain to the parent that, look, we are in a critical situation, your child is going into shock, all the peripheral lines have collapsed, there's a good line on the scalp, we'll just shave, but shave it, just enough, just shave what you need to get access. So clearly your scalp is not the first place that you go. But I think that if that's the only way you can save the child's life, the only place you can get IV access, you should counsel the parents and go ahead and set it there. And then, of course, carefully document what you did. As Gloria said, what did you do? Why did you do it? You can document the parent's request. I don't think any parent would like to see their child lose their life just because they want the child to have hair. So certainly if the parent requests, if you can respect it, please do. But sometimes you just can't. You just can't, and you need to secure IV access.
Thank you so much. Thank you so much. So please, I think this question will go to Anna, Mrs. Gloria. So this question says, if you're a health worker and you are assaulted by a patient's relative, a child's relative, can you also retaliate? And does that go against patient safety? Hello, ma'am, please, are you still on the call? Hello, please, can I be heard?
Yes, loud and clear.
Okay. Okay. So please, I don't know if Mrs. Gloria Mensah Bonsu is still on the call.
Yes, please. I
Okay,
think
so
I
please.
went off and came.
Oh, okay. So please, this question was asked by someone who wants a health worker who says, if a patient's relative, a child's relative, assaults you on the ward whilst providing care for the child, can you also retaliate? And does that go against patient safety? Thank you.
Oh, I think that ethically you cannot retaliate ethically because you are in the course of doing your duty. And I think that you know that you have to expect all those things, but you need to report appropriately for the law to deal with that person. But for yourself, no, you cannot retaliate because at that point, if you lose your sense, you may not be able to render the proper services that the child is required. Thank you.
Thank you so much. We have another question in the comment section. Says, regarding the child being a ward of the state. Oh, I think regarding the child being the ward of the state, some interventions cost money and some parents cannot afford such. Are there laws that incriminate a health worker? Should they discharge a child? Or are there structures in place? Oh, sorry. Or are there structures in place to assist the ward or the unit? How does a health worker navigate such a situation? Because I don't know who is going to take this one. Mrs. Grabos, please can you help us with this question?
If from my presentation under Article 34, we got to know that it's the state's responsibility to ensure that we all have good health and all that. Some facilities have been put in place, like the social welfare and all that, and NGOs and all that. So I think that in such situations, they can be contacted for them to come in and help. That's what I can say.
Thank you. Prof. Landru, please, have you encountered a situation like this, and how did you go about it?
Could you, which I missed the question.
Okay, so
I lost sound
they
a
say
bit.
the child is a ward of the state. And sometimes, and are there laws that incriminate a health worker? Should they discharge a child, or are there structures in place to support the unit? And how does a health worker navigate such a situation? Thank you.
So you're talking about discharge against medical advice?
Yes, please.
Yeah, okay. I mean, I think it's quite a complex topic. So when Gloria was speaking, she talks about how you're not allowed to refuse treatment on religious grounds, only on religious grounds. So there are a number of scenarios. A child, which I'm sure many of us have seen or been involved in before, where a child comes with an HB of 3, is definitely, clearly in need of blood, and the does not permit blood transfusion. We're not going to allow you to transfuse. That is a clear case where you can sidestep parental authority, and you should go ahead and give the blood. And I think the challenge that many of us face is the reality on the ground, because to be able to do this successfully and safely, you would need, for example, a strong social welfare support. I have worked with excellent social workers who, when you have such a case, you will call them, they will come. Oh dear. Maybe the host can.
Sorry, please, I've muted the person.
Okay, yes. Yeah, so you know, it's great if in such a situation you have an excellent, good, knowledgeable social worker who will hold your back, because we know that yes, it's the courts who are supposed to help you. But again, every pediatrician online will know that often there's just no time. Your child is breathless, the HB is 2, he's got, and they desperately need the blood, and you do not have the time to go to court and get a court order. By the time you finish doing that, your child will be dead. And that's where you need the support of social welfare to take up all these responsibilities of running around, getting court orders and all those things. And often the challenge is that support is non-existent. So clearly, if you have that kind of case, you must go ahead and transfuse. And, in some hospitals, there are times when we've had to call in hospital security. We sat down, we've counseled the parents and said, yes, we respect your religious beliefs. However, your child's life is at risk. If we don't transfuse the child, this child is going to die. And there have been times when we have very politely and respectfully brought security to escort families out of the hospital, and we've gone ahead and transfused. But it's difficult when maybe you're a house officer, you're all by yourself, in the middle of the night, and the family is threatening to beat you up if you give blood, and you don't have support of security, social welfare. It can be difficult. So clearly, yes, you have the right. And then there are more complex discharge against medical advice scenarios where it's not on religious grounds. The child has maybe a very advanced malignancy, and you have counseled them that, the prognosis is poor, and they say, we don't have, we cannot afford the treatment, especially when we know that this child is almost, is unlikely to make it. And then those are scenarios where you must sit with the family and talk and say, okay, you can't, maybe they live very far away. Is there another facility you can refer the child to where care can be taken, but closer to home? Is there anything that we can do to keep this child comfortable without keeping the child in hospital? Then it becomes an issue of counseling and negotiation. But clearly, where it is an acute situation and the parents are refusing on religious grounds, you can go ahead and give the treatment. And I think the courts will always back you.
Thank you, Prof. So there's a follow-up question to
Dr. Nelly, sorry to interrupt, but Prof. Titus is online and ready to proceed when you are ready to.
Okay, then I think we'll have Prof. Titus Bayu, and then we'll continue with the Q&A session. Thank you, everyone. So Prof. Titus Bayu, please, if you are with us, we are ready for you. Thank you.
All right. Good evening to everyone, and let me apologize for joining late. I had some conflicting programs, and having joined, I listened to my senior professor, Plandrew. I listened to Jukwa Plandrew. I listened to the other presentation. I guess say that a lot of the basic principles regarding patient safety has been covered. I'll therefore just make some preliminary comments because I'm not even in a position to share slides because I'm just in a moving vehicle now. And then maybe contribute to the discussions and questions that are ongoing. I would say that as far as the link between obstetric care, neonatal care, and patient safety is concerned, the basic principles I wanted to lay before all of us is that some parameters are needed to ensure patient safety. First, there is a responsibility of the states in terms of and owners of facilities. So where there are public facilities, then the responsibility lies on the state and the managers of those facilities to ensure that the environment, infrastructure, necessary equipment needed to ensure safe care is provided. It's a prerequisite to safe care. Sometimes our focus is always on the health worker. But when the basic equipments are not provided, basic infrastructure layout is not provided, then hard as the health worker may try, you will still have challenges to make sure that safe care is provided. And so if you have labor wards that are not very accessible, if you have the link between your labor ward and theater that is not accessible, if you have basic equipment in theater like diatomy that is not working, if planned preventive maintenance are not done routinely, equipment failure can occur and patients have died on the theater table simply because either biomedical engineers didn't do a pre-operative testing to be sure that oxygen flow is optimal, anesthesia machines are working appropriately, and all of that. So these are responsibilities of the state and facility managers to ensure that a safe environment is created. Then when you come to the side of the caregivers, appropriately trained caregivers are prerequisite to safe care. And so, and giving appropriate task based on patient, the staff, the cadres training and abilities is also important. So if you have a medical officer who is forced to conduct complex obstetric surgeries, cesarean section for someone with 3-4 previous cesarean sessions, previous myomectomy, that person is obviously operating above his capacity. But if there's no other alternative, and he not doing it means that there is the risk of death to mother or baby, then the person is forced to. That is letting the person operate beyond their capacity and can jeopardize patient safety. And so the staff and personnel must be trained and the task assigned them must be according to their capacity. Else, when you force people, then you have situation where the law comes in, but then the person is being forced to perform beyond his capacity. Then what happens? So I would say from the policy point, where we have the appropriate caliber of staff, cadre of staff, tax assignment should be appropriate per the person's training, experience, and skill level. But we must also, within the environment to operate, recognize challenges. You go to a district hospital that only one doctor is there. The person is a pediatrician, is an obstetrician, is a general surgeon, and is doing everything. So under that circumstances, how do we ensure patient safety? These are areas that we all have to think around. And when we are judging those people, we must judge them knowing the environment in which they operate, their own capacity, and what they have been tasked to do in the midst of that capacity. The final one I would say is that as far as obstetric care is concerned, caregivers must recognize that at any point in time, we are dealing with two persons, a mother and an unborn fetus, and we are dealing with an entire family. And people are very emotional when it gets to this state. And so the interpretation of your work as a caregiver the patient satisfaction of the care you give, how they perceive it may be different from what you know professionally. You can do your best, but that best may not be acceptable to the person receiving the care because of the lenses at which they are viewing the care that you are giving. So the emotional attachment associated with this must always be borne in mind when we are providing this kind of care. And I would say right from antenatal care, our communication, explaining things for patients to understand what is happening, intrapartum when they're about to give birth, our decisions, whether it's vaginal delivery or cesarean section, and making sure that where we are going for operative delivery, safety checklist is complied with, the WHO patient safety checklist is complied with, are necessary to ensure that there is safe care. And when babies are born, we must also, knowing the obstetric history, know which babies must be referred and which ones shouldn't. If we don't have the capacity, if you have delivered a baby of a diabetic mother, and you have neonatologists in your department, you have no business keeping that baby without having that baby assessed, because there are several things that you as an obstetrician or the person managing the pregnancy may miss, that it will take only the neonatologist to be able to pick to ensure that that baby is safe. Those babies, for instance, are prone to neonatal hypoglycemia, something that can be easily managed or prevented, but missing it can lead to death of those babies. That means that we've not created a safe environment. So I think based on all that have been said, these are the few things I just wanted to add. And also responding to some of the questions, I think the presenter just before me made mention of the fact that some service regulations permit children to be competent in a way in the sight of our regulations to take decisions for things like um, STI services or prevention, contraception, and they are not. There are some exceptions which she mentioned, and correctly so. And I'm raising this because I have seen some discussion on some platforms of mainly doctors where heated debate was there as to the appropriateness of a secondary school lining up girls to check why they have implants, and why the healthcare givers had to give young ladies like that implants for family planning. I mean, that is completely unacceptable that a school would do that. And first of all, these children will be ostracized. People will look at them as people who are evil, who are sexually active, and all of that. But the service rules our permit such things to happen. And so I would just want to put that in and say that I agree perfectly with what the presenter said. Those exceptions must be obeyed, and all managers of institutions must know, if they are not aware, that things like this exist. And where they are in doubt, they should contact the health service providers, and we explain to them the legal basis for which someone you will consider a minor can walk in and get certain contraceptive services without the presence of a parent. I would end here and then join in responding to questions. Thank you very much.
Thank you so much, Prof. Thank you so much. Very, very insightful. Thank you. Prof, please, we'll continue the Q&A session soon, but this one goes to you. Is it compulsory for a pregnant woman to attend ANC? We have seen instances as pediatricians where mothers are pregnant, go through the entire pregnancy without attending antenatal. No labs done, not on any medications. And then they just come when they are due and deliver. Is it compulsory for a pregnant woman to attend antenatal clinic? Thank you.
All right. To the best of my knowledge, and the lawyers are here, I'm a lawmaker, but I'm not a lawyer. So, to the best of my knowledge, there is no law that will compel someone to seek antenatal care. But it is recommended for the sake of the woman's own health and for the sake of the health of their baby. But there's no law to compel anybody to seek antenatal care, but it is strongly recommended.
Thank you very much, Prof. Thank you so much. So please, we are still going to continue with our Q&A. We have a lot of questions. We'll try and answer them. As many as we can. So Prof. Landru, please, this question was going to go to you before Prof. Bayo came in. So this question is with respect to blood transfusion once again. So if the parents are Caucasians, they are not Ghanaians, and they are in the country, and the child needs to be transfused, but then they refuse transfusion, are you permitted to go ahead and transfuse, knowing that they are, in quotes, foreigners? Do the laws of Ghana protect that child? Thank you.
Yeah, thank you very much. I read that question in the chat, and I would, my understanding of the law is that law is jurisdictional. If you are in Ghana, you obey the laws of Ghana in the same way that if it's a traffic law, you can't say that in my country the speed limit is 80, and in yours it's 50, so I can go 80 because I'm not. So yes, if a child, of a family that comes from outside you need to save the life, you should go ahead and save the life. But I would be interested in whether Honorable Mrs. Mensah Bonsu has a different view. That would be my understanding. I would go ahead and give that child blood.
Thank you, Prof. Hey, Anna Gloria Mensah Bonsu, please, do you have anything to add?
Yes, not to add, just to support what.
Oh dear.
Hello, Mrs. Mensah Bonsu, please, are you on the call? I think we've lost her.
Because in Ghana, the law provides territory. So that includes foreign children.
Please, we've lost you. If you're on the call, could you kindly repeat what you said?
Gloria?
Yes, please.
Okay, what I said was that I am supporting what Professor said, that in Ghana, the law provides for the protection and welfare of all children within its territory. So that foreign child, it includes that foreign child who is in the territory of Ghana. So all our laws are applicable to that child.
Yes, please. Thank you so much. Thank you so much. Please, Prof. Titus Bayo, please, there's a question in the comment section for you. If a mom with multiple gestation at 27 weeks loses the pregnancy during management, during managing a confirmed preterm labor on admission, all babies confirmed by ultrasound to be alive and well prior to the incident, uterine rupture confirmed by autopsy, do you write to the Medical and Dental Council alone or to the hospital or both for investigation, seeking a second legal opinion to help father whose world is crushed? Thank you. Hello, Prof. Bayo, please, are you on the call?
Early part of the question.
Okay, so please, I'm going to read it again.
Okay.
If a mom with multiple gestation, 27 weeks, are lost during managing a confirmed preterm labor on admission, all babies confirmed by ultrasound to be alive and well prior to the incident, uterine rupture is confirmed by autopsy, do you write to Medical and Dental Council alone or to the hospital or both for investigation, seeking a second legal opinion to help a father whose world is crushed? Thank you.
All right. So both are options available to the father. Medical and Dental Council, to the hospital, even to the law courts are all available. But the first thing will be, what is the objective that a person is seeking to achieve? If you suspect that the person who managed has not met a minimum professional standards, and therefore you want regulatory sanctions on him or her, then the Medical and Dental Council is the best place to go if you want regulatory sanctions. However,
Thank you.
if
Okay,
you
Prof, please
if
continue.
but if you want to get some explanations, institutional explanations on what would have happened, then going to the hospital itself is also an option. And if you strongly suspect that things have not gone the way they should have, and therefore you want to seek redress in the courts of law, it's also an option. And all options are mutually exclusive. You can explore as many as you wish. Thank you.
Which one?
Thank you so much, Prof. Please
Yeah,
kindly
could I
mute.
take a quick comment here?
Yes,
Just,
please,
just
Prof.
that,
Prof. Andrew.
just quickly, for a case like this, to recognize that again, you know, as Prof. Titus said, it depends on what you're looking for, but it's also important to remember that Medical and Dental Council cannot, for example, award damages. Medical and Dental Council has jurisdiction over doctors and physician assistants, and they will, you know, they can suspend or, you know, strike you off. But so if you're looking for legal compensation, then, you know, Medical and Dental Council may not be it's only the courts that can do that. You know, so as he said, it depends on what you are looking for. The courts, if you want damages, you must go to court. If you just want a doctor or a dentist or a PA to be checked, go to Medical and Dental Council. Thank you.
Thank you, Prof. Please, this question is asking, what are the rights of the unborn child? Example, if a baby needs to come out by CS, cesarean section, and mom refuses. Prof. Bayo, please, I think this question goes to you. What are the rights of the unborn child? Example, if a baby needs to come out by CS and mom refuses. Prof. Bayo, please, do we still have you on the call? Mrs. Guerabonso, please, can you help us with this question? Or Prof. Planjou, please, either one of you. Thank you.
All right, if we look at the Constitution of Ghana, the Constitution does not expressly define the legal status of an unborn child. So if you look at our laws, it seems like the unborn child does not have rights, but it has some statutory protection so that if you cause abortion or miscarriage without going through the necessary provisions of the law, it is an offense. It's an offense. So that if you yourself, you administer any obnoxious or poisonous substance to abort or miscarry, you will be charged as an offense that you have committed against the state. The exception is that abortion and miscarriages should be done by a registered practitioner in a registered hospital or clinic or maternity homes and all that. And it's where the victim has been defiled, raped, or the pregnancy is as a result of an incest, or if it is determined by a medical report that the unborn child may have certain abnormalities, or the pregnancy itself is a life-threatening situation for the mother. That one, I mean, it's lawful to do that. So depending on what is happening, maybe you have been informed that your unborn child will have certain serious abnormalities, or the whole pregnancy is life-threatening. That one, you can, I mean, it's not against the law. It can be aborted or evacuated by a licensed practitioner. So I don't know if I could get clarity on whatever she wants to say. That's what is the reason why she wants the child to be aborted, or I think I didn't get that part to be able to answer correctly. But
Hello.
this is the law. This
Yeah,
is the law.
hello.
Hello.
Yeah, good evening. Sorry, my name is Dr. Akun. I'm an OB/GYN specialist here. Maybe I can throw a little more light on that.
All right.
The question is whether the woman refusing cesarean section, when the woman there's a fetal distress, that the life of the baby is at risk, has to fall into bioethics, because at the point in time, the mother has the autonomy to decide. No, that's to sign the consent form for the surgery. So if the mother refuses to do that, so far as she has not given the consent, nobody can heal because an adult of 18 years old of sound mind, unless she was unconscious, where she has lost her ability to consent. Where at that time she has lost autonomy, because you wanting to save the baby, you are driving on the beneficence of saving the life of the baby. And at that point in time, the autonomy of the mother overrides the beneficence of the child. So what needs to be done is that, one, depending on the level of care, if it's a junior person, you have to involve the senior consultants. Sometimes even at the level of consultants, a person may still refuse the cesarean section. May have to bring in either the nurse manager's involvement. Sometimes it's a religious reason. Sometimes there's a fear. If it's a Muslim, you bring in an imam or even maybe a Muslim doctor available to come and talk. If it's a Christian, you involve the chaplain. You have to escalate up to every given point in time. But the most important is that document with timeline that around 6:35, I continue to talk to the woman. I continue to talk. So we need to continue to do that until consent is given. And this should be done with privacy and not with threats, because I've seen a quite number of them happens on the labor ward, and people can go all the way to the point that by the time they preach the baby is dead. And this is what happens. Maternal autonomy overrides the beneficence of the child, unfortunately. Thank you.
Thank you very much for your contribution, sir. Thank you so much. Wow. Okay. So, Dr. Mami Anyako says the challenge we face is the aggressive nature of patients' relatives when we have to provide care and they do not agree or do not have them, when they do not agree or do not have the money. Where should we report such cases? Social welfare has no funds at all levels. So where social welfare is handicapped, what do you do? Especially when the parents are threatening to leave the child with you if you don't allow them to take the child away or refuse treatment. Thank you. Prof. Planjou, please can you help us?
Yeah, so thank you very much. You know, it really is, the laws are very clear, but often the issue, as Mamiya is very rightly alluding to, is the implementation on the ground. Every single pediatrician online has had to put their hands into their pockets to pay for things. Just this afternoon, we had to do it. We had to do it to get a child, to get certain tests done for a child, because the family, for various reasons, was not able to do it. And we just had to quickly collect money and get the tests done. Ideally, there should be systems in place when it's a financial, you know, the family says we don't have money, we can't afford it, we are taking the child. You know, there used to be things like paupers funds, social welfare should be able to mobilize funds. But unfortunately, very often, many of our backup systems are very weak. And there have been times when we have been forced. I remember once, you know, one father in Confanochi many years ago, I mean, he was just so violent that finally social welfare actually advised us, what, let him take the child, because he was threatening to, actually bring in knives and things. The security people could not contain him. And it was very unfortunate because it was a condition that could have been treated. I suspect he probably had some mental health issues. So the theory is clear. Yes, you must protect the life of the child, but often on the ground, we lack the structures to be able to implement them. And no health worker must endanger their lives, in some of these things. So yeah, I mean, work with what you have, the other thing I think is important is if you have social workers, sometimes you need to involve them constantly so that they also learn how to handle some of these things, because sometimes they are also reluctant to get involved because they are not sure what to do. So I think that we all have an obligation to help make the system stronger and better. And I know that's not a great answer, but on the ground, we have many practical challenges that don't always allow us to implement some of the things that we are legally allowed to do.
Thank you, Prof. Planjou. Mrs. Grabons, please, this question goes to you. So the question says, do hospitals, please, in legal terms, who is described as a child capable of forming views? Who is described as a child capable of forming views? Thank you.
Okay. What we are saying here is that a child is a person below the age of 18 years. But you see that, let's say from 16 to 17 going, they are capable of forming views. So their views should be heard. And then we also have what we term as liberated children, or what we call emancipated minors. The street children and all that, the Kayos, they've been on their own for a long time. So those people they are capable of forming their own opinion. But I'll say that from 16 going, they are capable of forming their own opinion. And sometimes could be a child of like the adolescents, so like 13 going, you must ask their opinion. But the point is that their opinion will still not be absolute, because in any matter, you have to look at what will be in their best interest. So in as much as they can form opinion, it is still subject to whether it is in their best interest. So that is what I can say.
Thank you so much. Thank you so much. Please, we still have quite a number of questions to run through, but we'll try and end this before 7 p.m. I don't know who is going to help us answer this question, but the question is, the person is asking if hospitals have the rights of admission. Some patients are a security risk to other patients. So what do you do in that case? If a patient is a security risk to other patients, do you still admit them or you let them go?
So I will attempt.
Okay.
I don't. Well, when the healthcare givers have the responsibility to ensure that every patient in our care is safe. And so, in the interest of the safety of other patients, is the reason why we do isolation. So, when that patient needs to be admitted, but is a security risk to other patients, if there's an isolation ward, you should do so. If there is no an isolation ward, you should try and make the appropriate referrals. You just don't let the person to the wild. They could get psychiatric help. They could be referred to a psychiatric hospital if you think they are too aggressive based on a mental disorder, or if it is an organic disorder causing that level of aggression and that can be managed, you should. but you should never put a patient that you know will compromise the health of other patients in the midst of those patients. Then you wouldn't have been fair to the other patients that are already under your care. I think that's what I would say, but maybe others can add on. Thank you.
Thank you, Prof. Bayo. Mrs. Clarabos, please, do you have anything to add on to Prof. Planjou? Any comments? Thank you.
I think I agree. It's something that you do on a case-by-case basis. It depends on what's the reason for the patient being a threat to other patients. So, for example, I mean, we saw what happened during the COVID period. If you had somebody who had COVID, you certainly would not just admit that patient in the middle of the general ward. Clearly, you know, that patient needs special isolation. And if you do not have what it takes, then you must move that patient. And obviously, mental health. The Mental Health Act guides us as to what we can do with people who have mental health. I mean, how far can you do things like sedation, restraint, and all that? They are guided by, but no, you can't just turn a patient away and say you are a threat, so go away and go and die. If the patient is a threat, then you have a responsibility to see to it that whatever challenge this patient has is catered for.
Thank you. Someone is asking if children in the private facility have the same rights as children in the public sector, especially with regards to not having the finances for a particular service. I'm not. This question is quite interesting. Prof. Planjou, please, will you help us?
Yeah, I'll give it a shot. I guess what the person, does a child patient have the same rights in a private facility as in a public facility? And so I'm not sure exactly what the background of the question is. So things like discharge against medical advice. Obviously, your choice, you have a choice of whether to go to a public facility or a private facility. Private facilities are treating children who are under the laws of Ghana. So certainly they must look at the best interest of the child. On the other hand, you can't go to a private hospital and then when you are presented with a bill, you say, I can't pay. I mean, when you were going, you knew you were going to pay. So certainly people in private hospitals must treat children legally. If a child in a private hospital needs blood and the family is saying no, the doctor in the private hospital has the same obligation as a doctor in a public hospital. However, I mean, you know, as I said, if you choose to go to a private hospital, it means you are ready for some of the financial commitments, and it would be extremely unfair for you to take all the treatment and at the last minute say, because a private hospital, yeah, so I think that I'll just end that. That certainly all the children who go to any hospital have certain rights, whether you're in private or in government hospital. And doctors in private hospitals have many of the same obligations that those in public hospitals do. Yeah.
Thank you so much.
I would
Thank
have
you. I
liked to
think
give a specific scenario, but in general, that would be my answer.
okay, please. Thank you so much. So, Dr. Usu, your comment about if you tell them the child is for the state and they tell you you should ask the state to take care of the child, I hope that has been answered. So, as Prof. Planjou said, you take it on a case-by-case basis. If the parents are so aggressive and threatening, sometimes you just have to look at it and see if you can just let them go. Yeah, because you can't, if they ask you to take care of the child and you don't have a good social welfare support system in place, what do you do? Who's going to care for the child? So please take it on a case by case
Let me
basis.
just say that we have had children like that, where the parents have said, if you do give the blood, we will leave the child with you. We have given the blood. I don't know whether anyone has had a family who has said, okay, take the child. They often threaten. I've never seen anyone carrying it out. There are times when we have gone ahead and given children blood, and then at the end of it, they quietly take the child away. And so I don't think we should treat families with respect, do a lot of talking, a lot of counseling, but where the life of the child is in danger, you know, we should save the life of that child. And if they leave the child with you, you know, there are ways to handle such a, but I've never seen anyone do it. I don't know whether anybody online has actually been left with a child where the family have abandoned the child because you gave some treatment or other.
Thank you so much, Prof. So, okay, Dr. Duma is asking how we
There's a
can
hand,
get social
by the
welfare to
way,
be strengthened. There's a hand raised. Oh, okay, please, I
been raised
can't
for
see.
quite a
Kindly.
while.
Oh, okay, sorry, please. The
Sorry,
hand raised.
the name
Kindly go
is
ahead
Ed Ado.
Oh,
There's
okay,
a
I didn't see that.
Ed Ado.
Oh, okay,
Hello.
Ed Ado, please, kindly go ahead.
Oh, hello. Thank you for the opportunity. And good evening to panelists for the wonderful presentations. I wanted to add something briefly to what her worship said earlier regarding a question on a child capable of forming views. Like she said, right from the adolescent stages, the Children's Act enjoins us as health workers to give weight to these emancipated children, especially to their opinions and what their contributions may be. There are actually decided cases that provided a guide in handling this. And the first was the Gillick, in what became known as the Gillick consent. The guide was that if the child exhibits sufficient understanding of what they are looking for instance, they want some contraceptive advice or they want to go on the contraceptive, and they understand the pros and cons of what the particular choice of contraceptive is. And the clinician encourages them to involve their parents. And for one or two reasons, they refuse. And the clinician also realizes if you do not provide it, it may go adverse against the child, or they may do certain things that may compromise their safety and health. What the law decided, or what the court decided, was if the clinician believe, considering all these factors, it will be in the interest of the child to have the procedure or to have the advice or the implant, or whatever it is they are looking for, it can be done. So, in fact, it was recently challenged by another woman who thought she was a Catholic. And that rule, though it was a case law, which also has some force here in Ghana, she also challenged it again, the Supreme Court, that going by that rule or that ruling or judgment, it will mean that her daughters can receive certain treatment or advice that she, as a Catholic, may not want. Again, the Supreme Court sat on this and they confirmed and affirmed the earlier ruling that if the children exhibit those sufficient understanding and the clinician also thinks it is in the interest of the child, we can have it given. But on what Prof. Bayo said regarding what was happening on the GMA page, where some secondary school girls were picked out as having implants on their hand, if I do remember correctly, what the person was raising was not necessarily the fact that they've gone for the implants or that form of, but what she was questioning was whether that should be the first line for girls at that stage or age if they were looking for some form of contraceptive. What the person raised was, while this may prevent pregnancy, it may not protect them from infections, STIs, etc. And therefore, if they develop this false belief that the implant is protecting them on all levels of risk, then it may be misguided because they are still exposed to STIs and other forms of infections. I think that was what it was about. But in terms of the confidentiality, exposing them that way, or sometimes the way headmistresses wish to even conduct pregnancy tests in their offices, forcing these girls, these are unethical, it's unacceptable. And I think on a few occasions we've spoken against that. Then finally, on the blood transfusions, when parents are opposing, just like my boss said, Dr. Planju. Indeed, the difficulty I have it, the law, like her worship also said, it's already written, it's clear, it's black and white, that we go into, defend the interests through the welfare principle of these children over beliefs as respectful as we can, in the most cordial way as we can. But it should be emphasized for health workers to know that we don't stop our work, given the kind of HB Prof. Planju, for instance, raised, an HB of 3, 2, whatever. We don't stop our work to go to court to seek a court order. The law has already empowered us to rather, if it's necessary for us to rather proceed, they can rather go to court to possibly stop us if the judge thinks they have a case. But if we delay and allow something to happen to the child, or we waste time going to court rather, and something happens to the child, we can be taken on because the law has already given us the power to proceed after doing the necessary counselings, and if still there are obstruction, respectfully as we can, adopt or proceed on, we can get them out of the way and do what is necessary. That would be my little contribution to the discussions. Thanks so much, Doc.
Thank you so much for your contribution. Wow, it's been an interesting evening, very insightful. I hope we have all taken 1 or 2 points from the conversations we've had. And going forward, I hope we'll go back to our various workplaces with reformed minds and renewed knowledge and work appropriately to save the patients that we serve in the communities. Please, if there are no other contributions and questions, I'd like to thank all our speakers for being online, all our contributors, all the participants. But before that, we have closing remarks from the President of the Pediatric Society of Ghana, that is Dr. Hilda Boy. Dr. Boy, please, over to you.
Good evening, everyone. Thank you
Good
so
evening,
much
Dr. Boy.
Thank you so much for moderating this beautifully, Dr. Adade. And I would like to say a big thank you to the speakers that we have had, and also a special thank you to the president of the PR Watch Ghana, that's lawyer Isaac Ojiabo. We really appreciate this collaboration. We've had about 500 people on the call from around the beginning till now, which shows the interest that people have in the topic and how engaging the presenters have been. We had Prof. Planjrul talk about preventing harm in neonatal and infant care in Ghana. She went through quite a number of conditions under which you may have harm occurring or affecting the children in the various facilities. And then we had Prof. Bayo, Honorable Prof. Titus Bayo, who spoke about the link between obstetric care, neonatal care, and child safety in Ghana. Then we had her Anna Gloria Mensah Bonsu, who spoke about the rights of the child patient, upholding the welfare principle in healthcare delivery in Ghana. So this looks like we have had a crash course in medical ethics with a pediatric focus. And we are hoping that all the sessions have been useful for participants. And most importantly, we hope that wherever you are, you will look out for the interest of the baby or the interest of the child. And may this knowledge result in improved outcomes everywhere. Indeed, the children will come to us sometimes with concerns or problems, sometimes just to have us assess them or check them out. May there not be ever a time when under our care they will suffer harm that is preventable. The sessions have outlined the various roles that the stakeholders play, and indeed, it is not always within our power as healthcare professionals alone. But then, as much as possible, let the harm not be from us. Let the harm not be from lack of knowledge where we were supposed to be skilled or were supposed to be competent. Let the harm not be from us. So on that note, I would like to say a big thank you to you all again for joining us. And may we all continue to advocate for children everywhere in Ghana. Thank you.
Thank you so much, Dr. Hilda Boy. Please, in the comment section, we have the evaluation form and the CPD form. So please do well to fill the evaluation form as well. We really want your feedback on this webinar. Don't be interested in just getting your CPD points. Please do fill out the evaluation points for us as well. Thank you all so much for joining this webinar. I've been privileged and honored to be your moderator. Till we meet again next time. Have a good evening, everyone. Bye.
Bye bye. Thank you.